All right, thank you, Dr. Knowlton, and thank you for the department and the Innovation Center for awarding us this seat grant. I'll be discussing our initial go at the PIPAC for advanced GI cancers. I'll be presenting the majority of the slides, but Beatrice, who during her PD year was pivotal in helping me bring this to Stanford, will present some of the data that she collected as well. I have a disclosure that PIPAC and the delivery devices for PIPAC remain experimental in the United States and should be under a trial or registry. So as you all know, part of what I deal with here are the peritoneal surface malignancies. Scope of the problem for GI cancers is that about a third of these patients with gastric cancer will develop peritoneal metastases. Almost 20% of colorectal cancer patients will develop this as well. When you compare it to the other sites of metastatic disease, particularly the liver or lung, these patients always do poorly. And when you guys are on the floor or caring for these patients, oftentimes the complications of peritoneal surface malignancies such as bowel obstruction, ascites, and failure to thrive portend to a poor survival. They do not respond to systemic chemotherapy as well as the liver disease or lung disease, which makes this a particularly challenging state to treat. We know that in some patients, cytoreductive surgery and addition of intraperitoneal, whether it's heated or not, chemotherapy may help improve survival. The work of Sugar Baker and others have definitely shown that patients can have a prolonged survival when correctly selected. And when you look at it or break down how many of these patients actually get to surgery for HIPEC or cytoreduction, it's less than a quarter. So all the patients that we see in clinic, we can offer the surgical treatment or intraperitoneal treatment to a select minority. That brought this rationale of delivering regional treatment or regional chemotherapy for these patients. As we know, or as time has shown, systemic treatment really does not work for these patients. You know, as much as we give, very little of that chemotherapy actually hits the source. So these patients continue to do poorly despite the liver or despite the lung showing response. Using regional therapy, we leverage the peritoneal plasma barrier. So it allows us to deliver a larger or higher concentration of treatment, and we decrease the systemic effects of that regional therapy. So the hypothesis or the thought is by delivering that higher dose or delivering that more direct dose, we improve the activity of the treatment and reduce the systemic effects of it. And there's a potential for an immune or inflammatory response in the peritoneal cavity that hopefully we'll be able to leverage as time goes on, particularly with the broadening use of immunotherapy. So here, HIPEC is sort of the main regional therapy that we use for PSM. And this includes a rather large debulking surgery and then the addition of heated intra-abdominal chemotherapy at a very high dose. Normothermic intraperitoneal chemotherapy has been the traditional way of delivering this regional treatment, particularly with ovarian cancer. This was very popular in the early 2000s and remains a good treatment of choice for patients with gastric cancer. A lot of patients in East Asia are treated with normothermic intraperitoneal chemotherapy for management of PSM in gastric cancer. And then there was a development in sort of the late 1990s, early 2000s of a device that delivered intraperitoneal aerosolized chemotherapy that was pressurized. And this work really was the result of a Swiss surgeon, Marc Ramon, who basically utilized some of the devices that were already available. If you look at this device in box C, it was an aerosolized device to deliver lidocaine into the abdominal cavity after laparoscopic cholecystectomy or laparoscopic surgeries. He utilized that and the idea that if you pressurize chemotherapy and aerosolized it, you can potentially develop a more diffuse distribution of it and potentially penetrate the peritoneal disease at a much greater depth than what HIPEC or NIPEC could do. These are some experiments of his where he used a cadaveric bladder and attached his device to it And you could see that, you know, if you just instilled the fluid into that bladder, very few of it very little of it penetrated that sort of lining of the bladder. But when he attached his PIPAC device, with moderate pressure, he was able to get it to penetrate about 1 millimeter in depth. So looking at it as a whole, the PSM community sort of did start using it, particularly in Europe. It's a novel method of drug delivery where we pressurize and aerosolize the chemotherapy. Again, the hope is that it evenly distributes throughout the peritoneal cavity, so we don't have the sort of heat distribution problems that we have in HIPEC. There's no shake and bake. And then with NIPEC, where the patient is awake and alert and having them roll around on the table, you didn't have to do that. This was minimally invasive, or is minimally invasive, so this is laparoscopic. Here essentially is an outpatient surgery. Patients get the treatment and go home the following morning. And it allows us to go back, repeat our biopsies, look at the cancer in real time, and also repeat administration. This is a video of what it looks like. You can see the aerosolizer inside a balloon trocar. It's attached to a sort of an angioinjector that we've modified for this, and it essentially creates this snowstorm of chemotherapy. Obviously, the idea of pressurizing and aerosolizing chemotherapy is sometimes scary to certain people. This has been highly regulated in Europe and in Asia, and definitely as we bring it to the United States, the ISSPP, which is the society that sort of looks at these cases, regulates it, has a long-standing registry, provides training and certification for it. I had obtained training of this almost 8 years now when we went to Germany and in Singapore. We utilize the balloon trocars, as you saw. There's a safety checklist. Definitely PPE has to be available. And the amount of, or the sort of ventilation of the room and how we dispose of that aerosolized chemotherapy has to be sort of monitored, and definitely the steps of it were thought out with our OR team here. As we're delivering the chemotherapy, you'll see in some of the pictures we're standing outside of the room, and that took some challenges as well. In terms of looking at which patients we blocked or were not looking at, bowel obstruction and intractable ascites was the major one. Oftentimes, unfortunately, our patients present to the clinic with bowel obstruction, so that automatically disqualified a lot of these patients. And obviously, the relative patients that had extraperitoneal disease, this is strictly a peritoneal treatment. So the ones that had lung metastases or liver metastases that were not improving on systemic treatment should not or will not be candidates for this. Portal vein thrombosis, obviously, as we pressurize the abdominal cavity, this is not a great thing for these patients. So obviously, patients who have chronic portal vein thrombosis, fine. Acute, probably not. Extensive surgery, as this is laparoscopic, it is very difficult to get back in some of these patients, so they would be excluded, and obviously anaphylaxis to the drug treatments that we're giving. The amount of evidence that we have from Europe and Asia is limited, I will say, despite this having been utilized for almost 10 years now in Europe. The amount of studies, clinical trials, and randomized trials is limited. And a lot of it is because obviously the patient population is very heterogeneous. The types and different strategies of delivering the chemotherapy have kind of wavered as time has gone on. But I think in the past 5 years, the society has definitely moved towards standardization. And how do we achieve success, or how do we look at success? Most of it has been looking at survival after the initiation of treatment and the pathologic response. So when you look at some of these numbers, they may seem modest, but you have to remember these are patients that have been heavily treated with systemic chemotherapy, possibly surgery, and then now just starting from time zero, the amount of PIPAC that they've been given is what they're looking at in terms of survival. So again, some of these patients surviving almost a year despite being deemed non-candidates for HIPEC. in colorectal. Gastric, very similar, 6 months to a year in patients that were deemed non-candidates for cytoreduction. And then, obviously, the HPV community has started to embrace this in terms of trying to bring it to patients with carcinomatosis. It has less of an effect, but there's definitely more studies that are coming out looking at the efficacy of PIPAC for HPV malignancies. In sort of their sentinel paper, the ISSPP did release sort of their collective or collaborative effort thus far. And it's been published in several high-impact oncology, surgical oncology journals. And really, the idea is that if you can successfully deliver PIPAC in patients that were deemed unresectable, potentially 5 to 15% of them will eventually move on to getting a resection. And if not, the palliative effects or the reduction of symptoms, reduction of ascites, was definitely a measure that they were looking at, and it did improve in some of these patients. This trial, it was the first U.S. study. Some of the group at City of Hope, where I previously was, released this. Mustafa Raouf was my junior partner. Ton Dellinger was my colleague in GYN Oncology. And this was the first multi-center trial looking at PIPAC for the treatment of colorectal metastasis. It took a long time because they were seeking IND, IDE from the FDA. So it did take almost 10 years to get this study approved and finally published. And as you can see, very modest. They only had 12 patients in the colorectal group. But after the initiation of PIPAC in unresectable patients, they achieved a median survival of about 12 months. And again, their study is ongoing. They also looked at gastric and looked at ovarian cancer patients. And those studies or results will be released pretty soon. There are ongoing trials throughout the world. We in the United States are far behind, as it has been a little difficult to get this device approved by the FDA. But we're hoping as centers like ourselves and City of Hope and Mayo Clinic start doing more of these cases, we will eventually achieve FDA approval for this. So this started the hunt or the idea of putting this or starting this treatment here at Stanford. As many of you know, we see a lot of these patients. Many of these patients cannot have surgery, yet we see them in clinic repeatedly, and it's heartbreaking to not have anything to give them or anything to try. So the idea is the delivery of the PIPAC is given every 6 weeks. Sort of in between, we do give a dose of systemic treatment. And initially, we're only following at least the first 3 doses of PIPAC. Built into that, Beatrice will discuss some of the other things that we're looking at, but definitely looking at translational experiments as well as qualitative data. We've included gastric, appendiceal, colorectal. Patients have to have at least 2 lines of treatment before they come to our study for consideration. They obviously can have prior surgeries, and they must not be a candidate for CRS and HIPAC. So obviously, if they're candidates for cytoreduction, they go straight to that. Ascites can be a problem. If you think about it, we're dispersing chemotherapy, and if there's a liquid barrier, that chemotherapy is going to settle, and we're going to have a hard time reaching a maximal dose. No extraperitoneal disease for us right now. A bowel obstruction, as I mentioned, is not as a contraindication altogether. And obviously, if we can't have access via laparoscopy, these patients will be excluded. I'll have Beatrice talk a little bit about
All right, so this is more of a detailed look at the PIPAC protocol. So again, all the patients included had previously undergone standard of care therapy, including at least 2 lines of chemotherapy, with or without a surgical resection as well. So we would take them for a diagnostic laparoscopy to assess whether they're a candidate for PIPAC and make sure that they're not a candidate for cytoreduction. And if we deem them a candidate for PIPAC, then we would give them a baseline quality of life and symptom survey and offer them an interview to discuss kind of their experience and kind of their thoughts on PIPAC since this is a new therapy. So if they're a candidate, we plan for 3 cycles of PIPAC with 1 cycle of systemic therapy in between. We also saw them back in clinic for a follow-up and just to check in on their symptoms, make sure they're not having any adverse events, and check in on their quality of life, which we've been tracking at all of their follow-up visits. And at the completion of 3 cycles of PIPAC, we also assessed their peritoneal response. So just to give you an idea of what PIPAC looks like for each cycle, each PIPAC cycle consists of a diagnostic laparoscopy. We take 4-quadrant biopsies, and then we set up the camera and the wand, which is the device that delivers the chemotherapy. And those are set up with self-retaining retractors because we need to step out of the room. So we set that up, inject the chemotherapy, and everyone steps out of the room during the 30 minutes of dwell time. And after that is complete, everyone comes back to the room, and we desufflate and close. So this is a schematic of what that looks like. Here are some actual photos from the operating room. So you can see everything's already set up. You can see the machine there, the patient. Everything is self-retaining retractor. It's sturdy, it's not going to move. And as an extra layer of protection, there's a plastic covering, even though this should be a closed system for the chemotherapy. This is what it looks like when we step out of the room, and all the screens are facing the core. That way we can all keep an eye on patient's vitals and what's going on in there. And this is our anesthesiologist and surgeon looking on. So in terms of data collection and outcomes, obviously this isn't very well studied in the US, so we want to do our best to keep track of all of the data that we can as we do this at our institution. So we did make a prospective PIPAC registry, including obviously patient factors, the type of cancer and their treatment history. Of course, safety profile is really important. We want to make sure that they're not having adverse events, and assessing the peritoneal response, which I'll talk a little bit more about later. We're also interested in studying the patient experience. This is really important for this patient population because they're at the point where these are all palliative treatments for the most part. So we want to make sure that if we're offering a new therapy, we're not decreasing the quality of life. We're at least keeping it stable or hopefully improving it. And lastly, we have partnered with Dr. DeLito's lab for some translational studies. So just to talk a little bit about assessing peritoneal response, one way which I think most residents have probably come across by now is the peritoneal cancer index. So this is assessed by surgery. This is what we look for at each PIPAC when we do the diagnostic laparoscopy. It's a visual inspection of the distribution of the disease and the size and burden of disease in the different areas in the abdomen and the small bowel. Another way to look at it is the PRGS, or the peritoneal regression grading score. This is a pathologic assessment of the disease response. Obviously, this is done by our pathologist, and it's graded by the biopsies that we send them, and they look at the amount of viable tumor left and the amount of fibrosis throughout the treatment period. And lastly, RECIST. We don't actually use this for peritoneal disease because a lot of peritoneal disease is radio-occult and it can't really be adequately followed by scans. It's not a big tumor that you can see shrink over time, so we're not using this. So just to look at some of our preliminary outcomes, we've enrolled 6 patients so far for a total of 14 PIPAC cycles. We started this in April 2024, and our last PIPAC was actually just last week, a week ago. Unfortunately, we did have to pause for about a 6-month period due to machine issues, issues with accessing the machine. So this really just represents 6 months of collecting data. 3 patients have completed the full 3 cycles of PIPAC. 2 patients underwent 2 cycles, and 1 patient underwent 1 cycle. Of note so far, there have been no major adverse events in these patients, no issues with safety or access with the diagnostic lab in these repeat surgery patients. And 2 patients so far have stopped early due to disease progression. So far, we'll compile this when we have more data, but so far, everyone has had reported stable quality of life and symptoms. So just to take a deeper dive into the pathologic response, so of the 6 patients, we've had 5 patients who had pathologic assessment, and 4 of them have shown significant pathologic response, meaning a PRGS of 1 or 2, and that means they've had a major pathologic response or a complete pathologic response in that it all looks like fibrosis with no viable tumor left. So this is an example of one patient's tissue at essentially the baseline diagnostic laparoscopy. So you can see that there are a lot of, just to simplify it, a lot of purple dots, viable tumor cells. And kind of throughout the PIPAC treatments, it becomes more and more fibrotic. So the PRGS, the middle one, was a pretty major response, and they called it a complete response on the rightmost picture. And lastly, like I mentioned, we have collaborated with Dr. DeLito's lab, which is really exciting. We've been collecting tissue and ascites and storing them. Once we have enough, we're interested in looking at kind of the change in tumor microenvironment throughout the PIPAC treatments, because we do have the opportunity to collect repeat samples throughout, a treatment in the same patient. And they're planning to run this with single-cell RNA sequencing.
All right, thank you, Beatrice, for showing our initial data. And yes, we did have to take a 6-month pause as the device that we were using, we were no longer allowed to use, so we had to actually order a new one for ourselves. In terms of future directions, we will continue to gather institutional data, and actually we'll be rolling this out into thoracic. Dr. Bacchus is interested in using this in the chest for mesothelioma, and we'll also partner with GYN Oncology as well to open up future trials and registries. I plan to expand this to other institutions. We've had a lot of interest in joining our registry, and there are other institutions that have started to try to develop their own PIPAC program. But obviously, the amount of cases and the amount of treatments need to be pulled together and need to be standardized as an American effort. The DeLito lab is important to the surgical oncology department, and obviously collecting the tissue and processing it will be important for our future discoveries. I'm hoping to partner with Natera and looking at ctDNA within the peritoneal fluid. As some of you know, ctDNA for peritoneal carcinomatosis obtained through the plasma is not great. We haven't had a good showing of looking at it and monitoring response. But because we're able to go back into the abdominal cavity multiple times for this treatment, I'm hoping to identify or look at the trends in ctDNA of the peritoneal fluid. I'm hoping to have a training event on campus, so some of you will be able to meet some of these international surgeons who perform HIPAC and PIPAC throughout the world. I wanted to show this. This is 8 years ago. I went to Germany to learn how to do this. Obviously, I've been looking to do PIPAC for almost a decade now. In the corner is obviously myself, my former chair, Dr. Fong, and Tom Dellinger is the woman sitting in the middle. Mark Ramon is the gentleman sitting right here, again, the inventor and sort of the pioneer for this treatment. I started this obviously at City of Hope, and as I got recruited here, unfortunately couldn't do that first trial here in the United States. So it was tough, but thankfully the Stanford crew was able to help me get this here. A lot of thanks to DeLito and his real-world lab in Hague. Dr. Bingham, who is the pathologist who has been helping us do the PRGS. Cedar Fowler, our anesthesiologist, who's not been afraid of stepping in the room with chemotherapy floating around. Rense, who obviously some of you know has been faithful to us and coming and getting all the samples and doing all sorts of treatments different times of the day. Poltsides, who's not here, but he puts up with my crap and lets me continue to do these crazy treatments. The OR team, obviously, when we brought HIPAC here, it was crickets. Literally, no one wanted to work with us in the OR. So it took a select few people to start working with us, and as we go now, I mean, there really is no hesitation towards doing these cases, and we really have a good team. And obviously Beatrice, who has been great during her PD time and will continue to help us do this work, and for convincing me to keep going with this PIPAC journey. So I'll take questions at that point.